Go ahead.
So I haven't introduced myself because I got here late. My name is Marcia. I'm from Brazil, from the University of São Paulo. I work with the Yalza cohort with Mike is also involved. I'll just challenge you on that. We're good enough to drive cars, but we're still pretty bad at predicting when it's going to rain in 7 days. So there's just some stuff we can predict very well. Some that should be quite simple. I mean,
so you're saying we cannot predict hurricane? We predicted hurricane this year.
We can predict rain.
Oh, rain.
Is it going to rain? I mean,
I don't.
One thing is the shorter term it is for like weather. It's easier, and the more window of time you have, it's also easier. So I think we're in good shape with most of the scores we have to talk about like a 10 year. So within a 10-year range, I have enough time to some of the random things he's talking about. It's eventually will happen and we can do. But I think our power to get on the closer range enough to predict like a year or two is way tougher. And the truth is, which signs we have this far of like really high risk predictors that we've seen that are not rare. We don't. What we have sometimes it may be napkin ring or the tree high risk feature that we see on IVUS or OCT. Those are like a 1, 2, 3, 5% of the population. So if we want to trim that to have this top of the pyramid 0 point something percent, we might be able to do it at the expense of what Jagat said, a huge number of screening to find this part. But is it really worth it? Is this really what we want? Or should we aim somewhere like longer term, somewhat lower risk, more intermediate, and say, yeah, we're going to handle the 20% 10-year and focus on that. And even more, what I think we should do, keeping that on one track, is the other side of finding the lower risk from what we're doing wrong and stop treating people we don't need. And then we go on the risking from the calcium score 0 and other strategies that we say we can find people where we're kind of sure it's not going to happen in somewhat a longer term. And I think we're better off finding the safer side than the higher risk. And that would go, like if you get that JAMA paper, I think Jagat's one of the co-authors on JAMA cardiology, where they talk about the amount of obstructive disease you have prior to NMI. And it's pretty flat, stable up until 3 months before. And then at 3 months, you say that goes from 30 to 60, 70%. So there is something acute that is nonlinear, abrupt, that happens at some point. And their reference is something 3 to 6, 3 to 12 months. But it seems to be something abrupt, like a plaque rupture, that we're not really that good at predicting. So if we aim at that short period of time and try to get that event, unless we're on that period of time, we're not going to get it, and we're going to be wasting all the other measures that we could. Yeah. So should we aim at a 1 year 50% and shot everything at the guy that's close to that, or should we think about 10-year something else, intermediate, and then be somewhat more aggressive in there? But more than that, be more precise on that and kick out the ones we know or not. So we trimmed out to more precision. More precision doesn't mean we're going to get the 50%. Just mean we're going to kick out the ones we don't need and get somewhere in between. It might be more feasible. It might get less random stuff in.
Differently. That's what we've been doing so far.
It is, but I think there's still room to do that. We haven't been de-risking people for that long.
Yeah, but de-risking never is going to reduce MI. De-risking is a cost-effective argument.
It's also against harm. It's not just cost.
Right. I'm just saying it's not going to.
And feasibility of doing
if
what
your
we
goal
have
is to eliminate 600,000.
I think what we have listened done, like he's saying some very, very decent.
Okay.
He's really analyzing it very.
And one thing I was gonna, if the idea is like we're gonna eradicate, then we need a good bunch of primordial prevention. And then, I would just refer, one thing I like a lot, you just go North Korea project. It took them 40 years, but they went from 40 pounds of butter per year per person to less than 1. So then you have to go society. And then I'll go to what Dan and Jagat said. It's not, and even what you mentioned, it's not frightening the patient because, or the person, it's way beyond that. There's so much society around it. If you want to do primordial stuff, we're talking about social behavioral science, which is from advertising to getting the. It's like here in the U.S., guys drive through to mail, to food, and to the bank.
Yeah.
It's just so simple. This is not gonna work. You make cities without sidewalks, and like places like you go to LA, a block is 2 miles. That ain't gonna make. It doesn't matter how much you frighten people. That system doesn't work for what we recommend in terms of. You have to exercise.
Okay.
You have to walk to work. It's not feasible. So I think if we want to eradicate, we have a bunch more to do on the primordial part. But I think there's some room for go high risk. But I wouldn't aim to the very, very, very top end. I think we can step down a bit. Assume there is some random stochastic thing that we can't predict, and that has to do with time. So if you give us a bit more time from the 1 year and a bit less risk, then we have a bit more room to work and then target on people that were more visible. And then I think we should model a bit less than that.
I hear you. When we wrote this proposal to Google, one of the preambles was that it's well known, and Dan Berman is a walking example, so is David, because I watched that if you adhere to all of those low-risk behavior, diet, Mediterranean diet, and all that, you can reduce the attributable risk to 97%. You can bring it down. But when you look at U.S. population according to Enhance, you know what percentage of U.S. population fall in that category?
It's like 1%.
No.
2%.
Yeah, less than 3% of the entire U.S. population fall in that ideal risk category. American Heart made fool of itself for the last 30 years, saying the same thing again and again. What is going to change?
I don't know. That's why what I echoed the North Korean project that you can do from Finland, where they had all things wrong, and they did like it's. I think their last version of it's Global Heart. There's a whole issue about 82% heart attack reduction. So it's 82% less coronary heart disease over 40 years, basically on risk factors. And there's some interesting data in there because not only do they say it's 80% less, I think it's a BMJ paper of 2015 where they say if you sum what we did in blood pressure plus cholesterol plus diet plus exercise and sum it up, what we got is more. So when you do everything on the right direction, you can do even more than what you predict. There's a lot of the thing is it works. There is places
I
where
don't
it has
disagree
worked.
with you. I'm saying
But the thing
we
is,
have walking examples, but in this room,
U.S. hasn't been able to do that thing, also because of policy and the way the world is seen here. I'll say
only less than 3% of U.S. population fall under ideal risk profile.
And in Brazil, it's not that far better.
But I think that's a message to us as scientists and academicians to wake up and stop dreaming that we can get 97% of people to that 3%. We have to change our approach. Otherwise, we're just going to get the same thing. No, I don't disagree that population level, the Rose approach, that epidemiology, but we really need to do now. I'm not saying we're going to be able to do this 25% with the same approach. I'm relying on you, honest, Piotr, IBM Watson, and our unique cohort that we have to draw something that we don't know. I'm not going with what we know, but we don't know. When we come up with something, I mean, there's something happened to our patients. You just said that between 3 to 6 months, something happens.
Yeah, I'm curious. I would expect we would find that out, but the truth is we haven't. Yeah. And the only true.
But we never looked at it.
No, but
I mean, everything we looked at.
It's every 3 month CT scans or.
No.
But the thing is,
I'm just going to counter the machine learning argument a little bit here because the data we have is not that good. We have a baseline measure. If you actually had heart rate variability on a per second basis or per minute blood pressure or stress levels on a continuous basis, I think it's possible. But we don't have any of that. But the stuff that you're talking about there, all those stochastic measures, you need exquisite data, and that's what you said over and over. Someone said that showed the data going into the mouth. Right? Yeah. That's we need way better data than what we have to do what you're.
And even beyond that, when you look
at least you're saying we need data, so that's exactly
what we have data that's not in the cohorts that exists.
How do you know?
Because we only have baseline measures, and brought someone back in a couple of years and did another.
If you get 2,000 of patients, samples of people who had an event within a few weeks and months, and you delve into their blood, their imaging, their clinical information, and you feed it into machine learning. Do you think we'll learn more than what we have now? So I like your.
I don't think we have sleep. I don't think we have stress. I don't think we have their physical activity.
I think we're still missing the piece. It's not. I don't think processing better the data we will have.
We may not have physiologic data, but I think if you're able to get blood and do a thorough, you know that physiology is the end of the line. Between there are a lot of proteins.
It's the method. I think it's the data. In my opinion, if you just have a baseline blood measure, still that's not going to help you. It's just one baseline blood measure. Even if you measure every single protein.
But if that baseline was a few days before the event, that'll give you something.
I'll give you for a couple days. I think if you have that many.
So some people think it's a couple of months, like Dr. Bravo said. Italian professor. He made a good argument that day. This is 12 years ago, that there is a wave going, and the frequency or period of this wave is within 3 or so months. What's his name? Forgot. So and he's on our website. I don't know what the wave is. When I talk to the microRNA guys, they say a few days. Exosomes and other things, I don't know. But I think if there is a hope, it would go through this path that we're trying to dig this unique population. A few days before the event, few weeks before the event, they were, in clinic.
What the PMI guys are doing, taking all these, that's the kind of data that we need.
PMI.
Precision.
Oh yeah, that 20 years from now, you're not going to be able to get.
And maybe they can.
Yeah. Okay, we're going to wrap up. Thank you, gentlemen. Erling, can we give Erling the last word?
Yes.
Thank you. Can we give Erling the last word? Sorry. Erling and Mark.
What do you say?
You have the last word.
Yeah, I just say if you manage to find a mark or a fingerprint that can predict a heart attack in the next half year, how do you envision it should be implemented? Should all adults be tested every half a year to see what is the risk of having a heart attack next half year?
I don't know.
But it's an important question.
Yes, it is a very important question. It's absolutely. But it doesn't. It does.
It's in your Apple Watch. That's why you always say that the pathologist always has the last word.
That's right. For mine was reversed.
Thank you, George.
Thank you very much. Thank you. Thank you so much. We want to thank everybody online. I know there are quite a few people still online. We appreciate your tuning in. We will have all of these video recorded online. Thank you. Have a good evening.